There we go. You probably have to click on that. Ah, all right. Hello, everybody. Welcome to the History of Diving Museum. Welcome to our participants who are at a location and logging in through Zoom. In the chat, tell us who you are and where you're from and how many people are with you. If you have any questions, go ahead and put it in your chat box, and our moderator will be sure to get that to David. So my name is Lisa Mangilia. Welcome again to the History of Diving Museum, located in the beautiful Florida Keys. We have events like this through sponsorship for educational outreach. Today is free, both online and in person. Today we have Dr. David Charash. I've known David for a long time. He's won so many awards, I can't list them all, but thank you. He's part of a hyperbaric medicine. I know that he's cared for the diving community for over 30 years. He's a board certified in emergency medicine as well as hyperbaric medicine, has given many presentations like this. You can also find a podcast that he does on Spotify and Apple about diving fitness, which is really important for everybody these days. So we thank you for being at the History of Diving Museum and look forward to learning more about hyperbaric medicine, whether you're a recreational diver, dive master, instructor. Now with hyperbaric medicine, it's just a lot of good information. So thank you for being here.
Well, Lisa, thank you very much. And thank you to the audience for being here and wherever you guys are, undisclosed locations. I want to share with you a couple of nice things. First off, as a dive physician, I've had 29 to 30 years of treating divers, teaching divers. I'm a diver. I'm trained in emergency medicine, undersea and hyperbaric medicine. And as part of my clinical practice, I've had the opportunity to work with the commercial diving industry, scientific dive industry. I teach or have taught at the Naval Undersea Medical Institute, to the United States Navy Undersea Medical Officer candidates and the United States Coast Guard Academy cadets in their dive program, and have had the opportunity to teach both nationally and internationally on all aspects of dive medicine, dive safety, and dive technology. Recently, I've had the opportunity to do some research with Divers Alert Network, and I'll share that with you as part of the discussion. But I'm most happy about my most recent podcast, which I'm producing, called Fitness and Diving. And what it does is features conversations with divers, dive physicians, and scientists all about fitness and diving. It's really important that as a diving community, we understand the many aspects of fitness and diving, or what we can do as an individual to make ourselves as safe in the process of diving, whether it be for recreation or for work. So today we're going to talk about diving injury. Now, how many people in the audience are divers? Raise your hand. Okay, so most, but not all. And that's good, because if you are a friend of, or a spouse of, or a family member of a diver, it's important that you understand the issues related to diving injuries. So this will be really good, not only review for those of us who dive, but important information for those of us who don't. None of this should be scary. So if you're thinking about diving, don't let this stop you, okay? We're going to talk about the risks of diving, the incidence of diving injury. We're going to review the gas laws. It's really important that we understand the reality of what those gases can do on our bodies as we dive. We'll talk about the three entities of injury: decompression sickness, arterial gas embolism, emergent pulmonary edema. And we'll talk about, importantly, management, and as important, how we can perhaps minimize the risk to getting a diving injury. We will have lots of opportunity for questions. So along the way, if you feel you need to stop me, just raise your hand and we can, talk about it. But certainly at the end, we'll have lots of opportunity to have that discussion. So here we go. Whether you are is there any way of clearing that? Okay. If we can think about the classifications of divers, you're a recreational, technical, public safety, scientific, commercial, or military diver. And no matter what kind of diver you are, we all have the same risks in diving. And there are 6 basic risks we need to be concerned about. The risk of barotrauma, that is trauma due to pressure changes, decompression illness, arterial gas embolism, panic, drowning, and traumatic event. And again, whether you're recreational, technical, or military, we all have those same risks. But to maintain our safety and degree of fitness in diving, we need to be able to address medical fitness, psychological fitness, nutrition, physical fitness, knowledge, and physical skill. So at the level of a recreational diver who's diving 30 feet in the warm waters off the shores of Isla Morada, they need to have a certain degree of physical skill and knowledge and physical fitness compared to that military diver or commercial diver who's diving in the North Sea in a hard hat surface applied at 180 feet where the temperatures are frigid conditions at night. So let's talk about decompression injury and the incidence. How common is it to get bent or decompression sickness? And the answer is it's not that common, but it does occur. They estimate it to be between 2 to 4 cases per 10,000 dives as a total incidence rate. And it's more common in cold water dives. So if you're diving in cold waters, Scapa Flow up in the Northeast, the stressors of diving in the cold water can increase your risk potentially for getting decompression sickness. But when we try and ask the question and understand how accurate is that incidence of decompression injury, it's really a little unclear in the sense that when you get decompression sickness here on the shoreline, you may get mild symptoms. Your friend might put you on oxygen. Your symptoms may go away. You never report it to anyone. You don't go to the emergency department. On the other hand, those incidents that are reported are the typical severe decompression sickness in which you're calling 911, being transported to the emergency department, and then they call Divers Alert Network to give them more information or get more information, and there's more data coming in based on a self-reporting system. So the true incidence may be a lot higher than it really is, but it's not as common as we think. It's more common in recreational divers than in scientific divers. Now, remember, we talked about the different types of divers. So scientific divers, military divers have additional training requirements and medical fitness requirements than recreational divers do. So their physical skill, their physical fitness in a recreational diver may not be as sharp or as it should be than it would be for, let's say, a scientific diver. Their training and supervision is at a higher degree as a scientific diver than they are as a recreational diver. So we tend to see a higher incidence in recreational divers. Diving fatality is a statistic none of us want to be, but it's more common to die of a car accident in the United States than it is from diving injury. It's more common to die of a pregnancy-related complication than it is from a diving injury. And it's more common to die of a sudden cardiac arrest running a marathon than it is from a diving injury. But it's still not uncommon for divers. In other words, we think that 1 out of about 220,000 dives, we expect to see a diving fatality. And about 28% of those who have a diving fatality have about 28% of those people have some underlying heart condition or heart disease. So there's oftentimes a medical issue related to these diving fatalities. However, it could also be due to things like buoyancy training, they were overweighted, etc. Let's talk about the gases, okay? So let's define what an atmospheric pressure is. And this is important as the foundation for how the gases can affect our body and why it could potentially cause us harm if we're diving. So an atmospheric pressure is described as the weight of a column of air measured at 1 square inch from sea level all the way up to 32,000 feet in the stratosphere. If you weigh that column of air is 760 millimeters of mercury or 14.7 psi. That's 1 atmospheric pressure. So 1 atmospheric pressure equals 760 millimeters of mercury or 14.7 psi. Everyone got that concept, right? So that means that if I go from sea level out into space, the atmospheric pressure is less because there's less weight. Everyone get that concept? That also means that at sea level, if I go 33 feet below water, the weight of that column at 1 square inch from 33 feet to sea level is another 760 millimeters of mercury, 14.7 psi, or another atmospheric pressure. Everyone get the concept, right? So if we then look at sea level or 0 feet of seawater, we're at 1 atmosphere of pressure. If at 33 feet, we're at 2 atmospheres of pressure, right? The pressure from 33 feet to sea level and the 1 atmosphere above. And then the deeper we go, the more atmospheric pressure we have. And so now we're going to have a better understanding then of atmospheric pressure and how that affects various gases that will potentially put us at risk for decompression sickness, decompression, arterial gas embolism, or emergent pulmonary edema. So here we can see that at 0 feet of seawater, we're at 1 atmosphere of pressure. Right now, my lung volume is at 100%. I'm fully inflated and I have air in there. And what's at sea level right now? I have 21% oxygen, right, at sea level. My lung volume is at 100%. If I were to go to 33 feet below water, right, to 2 atmospheres of pressure, what happens to the air or the lung volume? It goes down by 50%. Everyone get that concept? So that also means that at 33 feet, when I come to the surface, my lung volume increases to 100%. Everyone get the concept? And so if I go from 0 feet of seawater to 33 feet at 50%, and from 2 atmospheres of pressure to 3 atmospheres of pressure, or 66 feet, my lung volume goes by 1/3. I can see that the air, the volume of the air, the gases, decreases in time, right? In depth. So increasing pressure affects the volume. And that gas law is called Boyle's law. It's the inverse relationship between pressure and volume. So if I increase pressure, I decrease volume. If I decrease pressure, I increase volume. Keep that in mind as we talk about the next gas phase. And here's a great example of that. At sea level, 0 feet of seawater, my lung volume is 100%. And look what happens at 2 atmospheres of pressure, or 33 feet, my lung volume is decreased in half. So this is what explains the issues related to barotrauma, or pressure and trauma because of pressure, related to anything that has air in it, like our lung space or sinuses or middle ear. The next law that's going to be important to review is something called Dalton's law. Now, if you remember in high school, junior high school, and now they're teaching this in elementary school, that at sea level, we're breathing 21% oxygen and 78% nitrogen, and the rest inert gases at 1 atmosphere of pressure. Everyone remembers that, correct? And that also means that if I were to go to 2 atmospheres of pressure, the effects of increasing atmospheric pressure doubles the partial pressure of those gases. So at 33 feet at 2 atmospheres of pressure, my partial pressure of oxygen and nitrogen double. See that on the slides? And that's important because when I start going deeper and deeper, the partial pressure of the gases go up, and I can start to get the toxic effects of oxygen or nitrogen. So I can get oxygen toxicity at greater depths, and I can get nitrogen narcosis at greater depths. Everyone get that? That also means that if I'm at sea level and go into a commercial airliner or a rocket ship and go out into space, the partial pressure of the gases are decreased. My oxygen levels will go down. Everyone get that? Okay. And the last one, I promise you, this is the last gas law, Henry's law. And what Henry's law states is that when I increase pressure, the gases that are circulating around in my blood and my plasma will be driven into the cell. So think about what's happening based on Dalton's law. At sea level, I have 21% oxygen, 78% nitrogen. At 2 atmospheres of pressure, I have 42% oxygen and 2 times 78% nitrogen. So at 2 atmospheres of pressure, increasing pressure, I now have Henry's law stating I'm taking that excess amount of nitrogen and moving it into my cells, okay? That also means that if I decrease pressure, Henry's law states that as I decrease pressure, we also refer to that as a decrease in ambient pressure, surrounding pressure, that the cell, the gases will come out of the cell into solution back into my blood or plasma. Does that make sense? So if I'm accumulating excess amounts of nitrogen in my cell at 2 or 3 atmospheres of pressure, when I have a change in ambient pressure based on Henry's law states that the gases will come out of solution into the blood and plasma. Boyle's law states that the volume of those gases will expand as I decrease pressure. So if I have a nitrogen bubble that was driven into my cell at 2 atmospheres of pressure, and now as I come to the surface, decrease ambient pressure, and the gases come out of solution, not only do I have the nitrogen going in my blood and plasma, but the volume of that gas, the nitrogen, will expand in size. Everyone get that? So those are the 3 gas laws as we talk about decompression sickness. So decompression illness is really the direct effect of these gas laws, both Henry's law and Boyle's laws we just described. Everyone get that? Because that's a really important concept. Okay. And when we take in these gases, they go into the cell, we come to the surface. So when we take in the gases, we call it on-gassing. When the gases come out of the cell into solution, we off-gas by exhaling. So when we're coming up from 33 feet to surface, as we're inhaling and exhaling, we're off-gassing and getting up that extra nitrogen. Everyone understand that now? Okay. So we all are familiar with our dive computers and dive planners, and we plan our dives and we dive our plan and we follow to a T our watches, our times, our depths, and rate of ascent. And even if you do everything perfectly by the book, you still can get decompression sickness. Okay, exactly. So you gotta do a little bit of this and a lot of that, right? Because these are just tables and computers, right? But we are all human. And each and every one in this room has a different physiology, a level of tolerance for amount of sleep, hydration, adipose, some more than others, right? And so all those variables can affect you in a negative way at some point. You could have had 1,000 dives of the same dive profile and never got decompression illness. And then on your 1,001th dive, you get that. So decompression illness is encompassing 2 different processes. One is arterial gas embolism, and the other is decompression sickness. Okay? And what is decompression sickness? Decompression sickness is when the nitrogen bubbles come out of the cell into solution, and as we off-gas them, they circulate around. And if we make a nice slow ascent, we get rid of our excess nitrogen, and we remember that we have some residual nitrogen when we come to the surface. But if an excess amount of nitrogen comes up too quickly, that can form a large bubble as it ascends. It could block an artery or a vessel, and you get no flow. And this is a pictorial of what decompression sickness looks like. That's a bubble of gas, nitrogen, that's blocking flow of blood. And when you have lack of blood flow, you have lack of oxygen. We call that hypoxia. And that triggers inflammation within the lining of the cells of the vessel. And that causes an inflammatory process. In addition, you're lacking oxygen, and that causes something called edema or swelling. Does that make sense? So you can see what that looks like, right? And so you get bubble formation. And it could be nitrogen bubbles, but it could also be helium bubbles. It could be any inert gas that comes out of solution. So if you're a mixed gas diver, you could get decompression sickness from helium, for example, okay? And in addition to the bubbles causing obstruction or blockage, there's that inflammation or inflammatory process. That inflammatory process is what causes further lack of oxygen, edema, and other factors that will give you the long-term effects of decompression sickness. So we can describe decompression sickness as either mild or severe. It's also referred to as type 1 and type 2. I'm using both of the descriptions because one of them, type 1 and type 2, is sort of old description, but still out there. But we can classify decompression sickness as either mild, which is typically pain-only bends or skin rash, itching. It's localized. Sometimes you can get swelling of an arm or a leg. Or severe decompression sickness type 2, which is either neurologic dysfunction, inner ear problems, pulmonary, or cardiac. Type 3 is when you have severe or serious decompression sickness. So that's neurologic plus air gas embolism. And arterial gas embolism is slightly different than decompression sickness. And we'll talk about that as another entity. So what are the most common signs of decompression illness? In order of most frequent is pain, right? And that's the most common presentation. So mild decompression sickness, that's a good thing, right? We'd much rather have a mild disease than a serious one, but we can also have serious decompression. So more common to have pain in joints or muscle. And then it starts to be a little more serious when you're getting numbness, you're getting fatigue, malaise, nausea, vertigo or dizziness or the room spinning around, muscular weakness, inability to walk, mentation issues, so confusion, disorientation, can't speak, and then bowel, bladder, so more neurologic dysfunction. So decompression sickness, the off-gassing of the nitrogen bubbles expand in size, causing blockage or obstruction, causing hypoxia, edema, the narrowing of blood vessels called vasoconstriction. And depending on where those bubbles go, can also cause this inflammation process, right? So that doesn't mean that as we all are going to produce nitrogen bubbles as we come to the surface, it doesn't mean we're all going to get decompression sickness. Remember, he said it's pretty uncommon, 2 per 10,000 dives, so not that common, but can occur. Decompression sickness is also something called probabilistic. Probabilistic means the probability of getting decompression sickness sitting in this room, unless you went diving today, is 0, right? Because we haven't had a change in ambient pressure. We're all on 21% oxygen and 78% nitrogen. But if you start to dive, the deeper you go, the longer you stay, the probability of you getting decompression goes up. Make sense? Okay. So depending on where those bubbles go and the amount of those bubbles and how quick they get there will give you different symptoms. So the bubbles can go to the brain, to the spinal cord, to the inner ear, the joint, the tissues, and the lungs. And here's an example of mild decompression sickness. So skin bends. Mild skin bends would be just itching, rash, maybe like raised hives when you get from allergic reaction. This rash that you see on the far left is called cutis marmorata. It's still sometimes referred to as mild decompression sickness, but about 10 to 15% of those who have cutis marmorata also have either some subtle or more severe neurologic complaint, and therefore it's not mild then, right? It's serious. So even though you may have this, this horrible looking rash, it looks really nasty. What that is the nitrogen bubbles are obstructing lymphatic channels in the skin. And you're getting that blotchy or mottled appearance. If you have no neurologic symptoms with it, and I would say unless you're a physician trained in emergency care, you're not going to likely be able to evaluate a fellow diver on the boat and determine if they have mild neurologic dysfunction. So when you have even something like this, they need to have medical evaluation. And here's an example of mild decompression sickness. So if the nitrogen bubbles go in the joints, you'll get joint pain, right? And how many people, whether you want to admit to it or not, have had decompression sickness? Any joint pain? Only one bold enough to say he got it, but probably most of you may have had something that you didn't realize.
So much pain for everything else in life.
Yeah. This isn't a psychiatric evaluation. All right, and then again, if the gas bubbles go on the inner ear, you'll get inner ear decompression sickness, right? And this is serious decompression sickness. It can occur from air diving or mixed heliox diving. And if the nitrogen comes out in your lungs, right, you'll get pulmonary decompression sickness, also referred to as a choke. And symptoms like this can present with shortness of breath, coughing, difficulty in breathing, chest pain, and you can go into acute pulmonary failure with this, okay? And then obviously if the bubbles go into any part of your spinal cord, the blood vessels to the spinal cord or your brain, you'll get central nervous system decompression sickness. Again, this is serious decompression or type 2 decompression sickness. So it's important to know that decompression sickness, we said it's probabilistic, right? So it occurs only if you're diving. But here's a question for the audience. Can you get decompression sickness if I'm diving on a boat? I go from sea level to 70 feet. And at 70 feet, I start getting back pain and weakness in my leg. Is it possible to get decompression
Oh,
Good.
while you're underwater?
Well, you're underwater at depth without any change in ambient pressure. In that situation, the answer is no, right? It's when you have to have a change in ambient pressure, right? And so therefore, when a diver comes to the surface, right, and they're off-gassing and they have a change in ambient pressure, that's when they start to see the signs of decompression sickness. And when you have decompression sickness, you typically get that first symptom onset within the first hour, about 42% of the time. So about 40% or more patients who have decompression sickness will have some symptom within the first hour. Within 3 hours, 60% of all cases will present itself. Within 24 hours, 98% of all cases, decompression sickness will present itself. And it'll be very uncommon to see decompression sickness beyond 24 to 48 to 36 hours. And that's important because if I did a single dive today, right, and 5 days from now, I start getting back pain or elbow pain, that's not likely because of decompression sickness, right? The probability says that's not related. It's an unrelated event. Yes.
But it also have to do with the depth that you go.
Well, it does.
I dove this morning, I didn't go deep in 20 feet.
Yeah, well, we're going to talk about that. We're going to talk about that. But the answer is depth is going to be important, right? The deeper you go, the increase the depth. But the point being that if you're going to get decompression sickness, you're typically going to have a certain time frame. Now, mild decompression sickness is the most common form. If you have severe decompression, it usually happens early in onset. So if I come up from diving and within a half hour or so, I'm starting to get weakness in my legs, difficulty in speaking, right? That's serious decompression. You expect to see that earlier in the process, okay? So I mentioned to you that I do research with Divers Alert Network. I'm a volunteer researcher. This is the research team, and it's a collaboration between Divers Alert Network, University of Maryland, and University of North Carolina. And we're looking at the cardiac effects of diving and dive injury. We're getting cardiac markers to look at the inflammation. We're also doing echocardiograms, ultrasounds of the heart, so you can actually see when the divers come to the surface, they're off-gassing, and the bubbles are circulating around in the heart, and we can measure the amount of bubbles. Now, many of us will make bubbles. We're called bubble makers, right? And you can be, and we typically, the divers will be at 70 feet for a period of 20 minutes or so. They'll come up for a decompression stop and a safety stop. And when they come to the surface, within the first 10 minutes, they're getting ultrasound. We get urine and blood testing and set of vital signs. It's a pretty elaborate sort of thing. What I wanted to share with you, though, is not really the details of the research, but some of the interesting phenomena here. So let me just see if I can get this here. So this is an ultrasound machine. This is the heart. And what we're doing is we're putting the ultrasound probe on the chest wall, and we're going to be looking at the blood flow, and we're going to watch for bubbles. And the scientists can actually calculate the number of bubbles. And we also will be repeating this every 20 minutes until the person no longer is producing or off-gassing the bubbles. There you go. So you can kind of see on the left side of the heart, right? You see all those little bubbles? Those are nitrogen bubbles that have come out of circulation and going through the heart. So the nitrogen comes out of the cell into the blood and plasma, goes through circulating the heart, and then the blood is pumping that, the heart is pumping the blood to the various parts of the body. So if you have a lot of excess bubbles, right? If the bubbles happen to get trapped in a place like your inner ear, you get inner decompression sickness. Now, these divers have absolutely no symptoms. So they're making lots of bubbles, but they don't have decompression sickness. But it's a pretty cool thing to see, right? Okay. So that's decompression sickness. And then let's talk about arterial gas embolism. Okay. Arterial gas embolism is different than decompression sickness in the sense that it's not an issue related to off-gassing and nitrogen or helium. It's due to air, due to some trauma or injury to the pulmonary system or pulmonary barotrauma. And the most common cause for arterial gas embolism is breath holding on ascent. So think about Boyle's law. And if we look in the anatomy, the pointers won't work on the screen here, but at the small end of the lungs, they're called alveoli, little air sacs, right? And they're filled with air, okay? And as we come to the surface, the volume in the air in the alveoli are going to expand based on Boyle's law, right? And if I were to hold my breath on ascent, what happens is you get a sudden delta change of volume in the alveoli, and the alveoli break, and now you get a collapsed lung, and the air goes into the pulmonary circulation. So I have air that's now just floating around. And what happens to the volume of the air as it comes to the surface? It's increasing in volume, and it gets into my circulation, and it sort of causes the same process of blockage, obstruction, hypoxia, and inflammation. So that's called an arterial gas embolism. Now, we mentioned that as we ascend from 30 feet to 0 feet of seawater, we go from 50% lung volume to 100% lung volume. But the change, the delta change, is greatest at the first 4 or 5 feet of the surface to 4 or 5 feet. So I could be at 5 feet of water or 20 feet diving, hold my breath on ascent, and come up with an arterial gas embolism, but not get a decompression sickness from nitrogen. So our friend is correct that the likelihood of getting decompression sickness, again, nitrogen, at 30 feet, 20 feet or less is close to zero. You need, in the US Navy dive tables, 420 minutes at 30 feet to even come close to getting decompression sickness. 20 feet, you're not going to get decompression sickness, right? Assuming that your computer is correct. You did, like, you know, do a little bounce dive, right? But you could certainly have had a rapid ascent because of panic, ran out of air, right? Hold your breath for whatever reason, or maybe you have some underlying lung issue, could be another cause for pulmonary barotrauma. So I have asthma. You can dive with asthma as long as you're stable and medically clear. But if I am diving and my asthma is out of control, that could potentially increase my risk of pulmonary arterial gas embolism, pulmonary barotrauma. Same thing with diving with a lung infection. So in the era of COVID, when, you know, a lot of us got sick and we had lung infections, right? We need to be able to clear ourselves medically before we consider going back to dive, because the risk of diving with a sort of partially treated lung infection can increase the risk for arterial gas embolism. So arterial gas embolism, different than decompression sickness. When you have arterial gas embolism, we typically see the symptoms begin immediately on surfacing within the first 5-15 minutes, in that range. Compared to decompression sickness, where we said mostly mild, usually an hour to 4 hours to 24 hours. All right. So we can differentiate based on the symptoms. And we also know that if the likelihood of getting arterial gas embolism, the most common cause is breath holding on ascent, understanding the dive profile. The patient rocketed to the front, had an uncontrolled ascent, ran out of air, saw a shark for the first time and bolted to the surface, right? Or some had medical issue, and now they're at the surface, and now they're unconscious or having significant neurologic symptoms. We're thinking this is possibly an arterial gas embolism, right? So I showed you decompression sickness. Now I'm going to show you arterial gas embolism. So this is the setup for this. So in the Navy, if you are in a submarine and the submarine gets lost at sea and you're at 350 feet and they don't have the ability to come and rescue you, they do something called submarine escape training. They put you in a 30-foot swimming pool, right? All scuba divers, all submariners, right? And what they're going to train you to do is get in a special suit, walk out of the submarine at 350 feet, exhale, and swim to the surface. You'll be in like for lack of better terms, almost like a condom, right? That's getting a little like 5 cc's of air in it. And as you start kicking up, what's going to happen to the volume of the air in your outer suit? It's going to increase in size. Your buoyancy is going to go up, right? You're going to shoot up at about 350 feet a minute, right, till you get to the surface. And while you're doing that, they train you to exhale continuously. Otherwise, you'll get pulmonary barotrauma. So they estimate that it's actually survivable to do this at 1,200 feet. Okay, that's what these training is designed for. It doesn't mean survival doesn't mean you're not going to have injury, and it doesn't mean everyone's going to survive. Okay, so this is the training. This is actually the Royal Dutch Navy submarine escape training. I'll walk you through this. Okay, so the diver on the left is the student, the diver on the right is the instructor. he's going to remove his face mask and have him pretend to shoot up to the surface. All the while, he's got to be exhaling. You tell him to say E. You go E, right? And we're blowing bubbles. Now, as he makes his way, look at that. He's barely exhaling. You can see that. And watch when we see the camera from above. As the camera shows above, the instructor above will recognize he's not exhaling much. See that? So he's going to get tapped on the head and be reminded, you got to blow bubbles. Exhale. So here comes the tap. Now he's going to blow bubbles. See that? Okay. Now watch him as he comes to the surface. So the most common cause for arterial gas embolism is breath holding on ascent, and it usually occurs within surfacing immediately within the first 5 to 10 minutes. And now he's getting blowing bubbles nice and now, right? He gets to the surface. Okay, remember the greatest delta change for volume changes is 0 to 4 feet. Now at the surface, he's got to swim to the edge of the pool. I want you to pay attention underwater to his left and right fin. Remember, the most common symptom is neurologic. It usually occurs at surface or within the first 5 to 10 minutes. Look at his right fin.
Yes.
It's not moving. He has an acute arterial gas embolism because he was breath holding on ascent. So different than decompression sickness, but you can get the same sort of symptoms, right? But the timing is clearly different, right? Arterial gas embolism. Yeah. So the goal then is to recognize that you got something wrong, right? And the first sign of decompression sickness from the diver side is denial, right? When you get up and you have a problem, you're not going to say, hey, I've got some elbow pain and I feel really weak and tired. You're probably just going to go sit on the corner and be isolated and try not to bother anyone. So a lot of times it's the rest of us as, part of the team, right, that can recognize that the diver may be at harm, okay? And again, when did the symptoms begin? Is it acute, immediately on surfacing? Was it rapid ascent, prolonged bottom time? I dropped my knife, I went an extra 30 feet down, I stayed longer than I should have, I made a rapid ascent. So in addition, there are other things that can occur, including medical conditions, right? Other things can occur. One of those conditions is something called emergent pulmonary edema. And emergent pulmonary edema is when you take a body and you immerse it in cold water, right? And we see this in young, healthy athletes, marathoners in the military. It's called swim-induced pulmonary edema, or SWIPE. I can go swimming and suddenly the cold water forces force the blood from my arms and the legs centrally into my core, into my thoracic cavity, and that excess amount of blood in my heart is pushed into the lungs, and I get emergent pulmonary edema. It's more common in divers who are older or have unknown or known heart disease. And if you get emergent pulmonary edema once, you can get it a second or third time. So if you get the symptoms of emergent pulmonary edema, how you differentiate this from decompression sickness is typically this occurs when you're at bottom. Right, I go from the surface down to 70 feet. I'm doing my thing and suddenly I start coughing and become short of breath. I have difficulty breathing. And then I start making my way to the surface and I have fluid pulmonary edema, or CHF, and I can't breathe, okay? And the story or the dive profile is I was fine on descent. I was at bottom and then symptoms began. Again, that wouldn't be decompression sickness, right? Because you'd have to have a change in ambient pressure. So we can differentiate emergent pulmonary edema from decompression sickness based on the story. Risk factors. So as we get older, we have other decompression stressors, right, that can affect us. Remember, when they did these initial dive profiles, they did it in young, healthy, military, Navy divers, right, who have no medical conditions, they're not overweight, for the most part, are not big-time smokers, vaping, all the other things that we are involved in, right? Exercise, you can increase the risk if you're exercising before or during dive. So what do we do when we go from our parking lot with 2 tanks on our shoulders, with all our gear, walking to the shore, getting set up, and then walking into the shoreline or getting our gear? We're doing heavy physical exertion, probably sweating a lot and also getting dehydrated, right? So dehydration is another variable. Obesity. Okay, so why is obesity an issue? Because the fat loves to hold on to the nitrogen, and it takes a lot longer for the nitrogen to come out of solution, so it's in there much longer. So you're gonna have more residual nitrogen when you get to the surface, even if you do in a proper surface interval, okay? And then obviously an acute injury to a joint space, when you have blood, trauma, injury from a sprain or a fracture, and if nitrogen is circulating through it, it doesn't have an easy way to get in and out, and you get kind of hung up there, and that can cause perturbations of the nitrogen bubble, which can rapidly expand. And then obviously we mentioned diving in cold water versus warm water. It doesn't mean that diving here, you can't get hypothermic and you can't get bent in the warm waters of Isla Morada. Dive profile is also important too. I don't know your name, but our friend over here who mentioned, well, I'm at 20 feet, I can't get bent. And the answer is, you're right, you probably can't get bent. But the deeper we go, the longer we stay down there, we're increasing that nitrogen load, right? We're increasing our risk. And when we think about a rapid ascent, right? And the reason we take a nice slow ascent, we don't want to have any pulmonary barotrauma, we won't have enough time to off-gas the nitrogen, right? So think about what happens in I used to bring a Coke bottle and demonstrate this. I did it when there was a white carpet, so I don't do this anymore.
Thank you.
You're welcome. So just think about a Coke bottle, big liter, right? And we shake it up, right? Okay. If we kind of crack the lid a little bit, nice and slow, we see a couple of fizzes, right? It comes out of solution, not bad. But if I go a rapid change in ambient pressure, what happens? All those bubbles come out of solution. So a rapid change in ambient pressure, so rapid ascent. That's why we do it for recreational diving, that safety stop, it gives it extra bit of time, right? We don't want to, have any other issues like that. Repetitive diving. So we know that if we do a single dive, within 24 hours, we get rid of all that excess nitrogen. Repetitive diving, you get residual nitrogen, you have a surface interval, but you have some residual nitrogen left over. You make your second dive, you've got new excess nitrogen plus your residual nitrogen. So you're increasing the probability of having some issue, okay? Reverse profile diving, it used to be felt that you should always do your deepest dive first, and then you do your shorter dives afterwards. And the reality is that that has been disproven as a cause for decompression sickness, as long as you can account for the appropriate surface interval for the amount of time you're down. Other risk factors include flying after diving. So there are clear recommendations. This is from Divers Alert Network. So a single no deco dive, we recommend that you don't fly after, wait at least 12 hours, and think about what's happening in a commercial airliner that's going to 32,000 feet. The plane is actually pressurized to 8,000 feet, right? And that's at 32,000 feet. They go from 32,000 feet to 8,000 feet, from 8,000 feet to sea level again. So you're having changes in ambient pressure. So when you do repetitive dive, multi-dives or deco dives, right, you're going to have an increased chance of having some residual nitrogen that could potentially off-gas. So obviously for the deco dives, you're going to do greater than 24 hours. For repetitive dives, at least 18. But for my purposes, if you do more than one dive, anything over 24 hours is reasonable. And if you're doing real technical diving, you probably want to consider longer than 24 hours. Okay, so the goal here, we already talked about decompression sickness, arterial gas embolism, and emergent pulmonary edema, but we're not talking about other conditions that can cause diving injury, including things like gas contamination or medical injury. So Lisa will have to invite me back for that discussion another time. So what do we do on a pre-hospital setting, right? First aid, right? So everyone should have some sort of training in first aid and oxygen administration, right? Oxygen is really found to be the most helpful thing when someone has a diving injury, okay? Also calling 911, those should be done simultaneously. It's not linear where you do one, then the other, then the other, then the other. If you have a team of 4 people, one's getting the oxygen, one's calling 911, one is, letting the boat captain know what's going on, okay? And then the other part of this is when you go for help, you go to the nearest emergency department, not necessarily the nearest place that has a hyperbaric facility. And the reason being, I live in Connecticut. We have 32 hospitals, 22 hospitals have hyperbaric chambers. The Navy has 2 multi-place chambers. in the entire state of Connecticut, if you get decompression sickness, there isn't a single place that will treat you in the entire state.
What?
Correct. No one will treat you with decompression if they have to air evac you or take you by ambulance to New York or Rhode Island. So if I thought that, let's say Hospital X, which is 30 miles from diving from NOAA, Connecticut, has a hyperbaric chamber, I bypassed the emergency room to get to that wonderful place that has a hyperbaric chamber, but they're closed, they're not available, they're not staffed, the machine's broken. I bypassed the emergency department. I also said that it's not as common as things like heart disease, pregnancy-related conditions, medical emergencies. So if I was having a heart attack or a stroke and I happen to be on a dive boat and you bypass 2 emergency departments to go to a hospital that may be not available to me, I may not even make it that way. The other thing to think about is that access to hyperbaric programs that can actually treat you are problematic throughout the United States. And what I mean by that is if you're in Connecticut, they're going to transfer you to New York or Rhode Island, assuming there's a place for you to go. Otherwise, they have to sit you out to Philadelphia, right? So that's a big difference. And think about all those New Jersey wreck divers. When they get injured, they go to Philadelphia, right? They're not coming to New York. So when you go to the nearest emergency department, they can get you on oxygen, make sure you're not having other medical emergencies. And they have the ability to contact Divers Alert Network, and they actually can inform them where the nearest treating recompression chamber is and help make that transfer. We are also, and many of us are familiar with Divers Alert Network, and I'm not here to sell Divers Alert Network or insurance. That's not my role here. But the idea is that it's important that you do call Divers Alert Network. You don't have to be an insured member to call them. You will be able to get 24-hour advice from a dive medic who will go through a series of guidelines to help you decide what you need to do, where you need to go. But you shouldn't call Divers Alert Network before you call 911. If you need emergency care, get emergency care, and then call Divers Alert Network. Let them know you're going to the emergency room, and then they can make the connection with the ER doctor. All right, so let's talk about oxygen and why is it so important? It accelerates inert gas elimination. So again, we have nitrogen, we want to get rid of that gas. So even surface oxygen will do it. It'll reduce the bubble size. Remember we said bubbles can affect, all right? It also enhances oxygen delivery. We said hypoxia occurs during decompression sickness. And there's swelling, we're gonna reduce the swelling. So surface oxygen at the highest concentration will do all that. Not even hyperbaric oxygen, the surface. So 100% non-rebreather, highest percentage of inspired possible oxygen. So you need to be familiar with the different delivery devices to determine what is the best thing that I can give at the highest concentration that I'm capable of delivering. And the only way to really do this is to be trained or certified. I don't like to say certified, but trained in emergency use of oxygen. Okay, and you can do that either through DAN Emergency First Aid or any other training organization that has oxygen emergency training. Okay, so let's talk about hyperbaric and treating decompression sickness and arterial gas embolism. The picture on the top is a patient in a monoplace chamber. So a monoplace chamber takes one person at a time, monoplace, and it delivers oxygen to do a efficient table 6. We'll talk about what that means for both decompression illness, decompression sickness, and arterial gas embolism, or a multi-place chamber. Multi-place chamber means more than one person can go in there, okay? There are few and far between multi-place chambers in the United States, but lots of monoplace chambers. And we all would agree from the hyperbaric community that whether you go to a monoplace or a multi-place, it doesn't matter. You just got to be treated if you need it, okay? So the treatment, of course, initially, again, surface oxygen, first aid, medical evaluation, and then we decide, okay, you're a candidate for hyperbaric oxygen therapy. So now we're transferring you, you're at the place, we're going to put you in a hyperbaric chamber. What does it actually mean? The treatment for arterial gas embolism or arterial gas embolism is a treatment table 6. Now, what does that mean? The United States Navy dive manual has 14 different treatment tables, and there are probably a total of 22 different treatment tables worldwide. Table 1 through table 14A in the United States Navy dive manual. Treatment table 6 is specific for decompression illness, arterial gas embolism. So what I'm going to show you here is that when everyone sees the arrow here? Yeah. So we're at 0 feet of seawater, right? We put you in the hyperbaric chamber, and we pressurize you down to 3 atmospheres of pressure. And we do that in dark green is 100% oxygen. And we're going to keep you on 100% oxygen for a total of 25 minutes. And then we're going to do something called an air brake, the light green. Now, why do we do an air brake? Because at the high concentrations of oxygen, you're increasing your risk for oxygen toxic effect, like seizures. So we give you an air brake, so we minimize that from occurring. And then we put you back on the dark green, 20 minutes of 100% oxygen, 5-minute air brake, 20 minutes of 100% oxygen, 5-minute air brake. And then we bring you up to 2 atmospheres of pressure, okay? And then we keep you there for 60 minutes. And then we give you a 15-minute air brake and then another 60 minutes. Now, when you first went in, we examined you. We found you to have weakness, problems speaking, maybe urine problems, okay? Once we put you to pressure at 60 feet, we then reevaluate you, okay? Kind of see, are you improving? And if you're improving at 60 feet, that sort of suggests decompression sickness, right? Because we maybe shrunk the bubble, decreasing inflammation, improving hypoxia, edema reduction. Let's say we get out to that second 60-minute treatment here, and you're still having symptoms. We may need to do something called an extension, which means we have to go another 60 minutes. Now think about this. The total time for table 6 is 4 hours and 45 minutes. And I think you saw that yellow chamber outside the museum. That's a monoplace chamber too, right? So a multi-place chamber, the one that I showed you, is a bit bigger. It's 38 inches in diameter, but you're lying in there for 4 hours and 55 minutes, a monoplace chamber. If I had a choice, I'd much rather be in a multi-place chamber, but most of us won't have that luxury of choice. But you've been in there for almost 5 hours, and you may need to be in longer. So let's say I've had a treatment table 6, and either I can't tolerate it anymore, or I just got to get out. Then the doctors will decide, do you need additional treatment? And they can either do another treatment table 6, they can do a treatment table 5, which is a shortened version of a treatment table 6, or they can do a treatment table 9. And you don't need to remember any of these numbers, but suffice it to say that there are additional treatment tables that you can do as second and third treatments. And there are other situations in which you need additional treatments. We call those tailing treatments. Those tailing treatments can be typically performed in the typical wound care mode, which is what this treatment table 9 is. So you have a variety, but the bottom line is I just want you to see what that dive profile is in the chamber. It's an extensive situation. This would be really bad day. This is if you're a commercial diver, mixed gas diver, and you're in a multi-place chamber, right? This can go down to 165 feet, right? And this would be something like a 6-hour procedure. And a lot of times for the commercial divers that do something called saturation diving, they may be at this level with mixed gases for up to a week in the chamber. So it's a long. Now, what if you are a technical diver, research diver, working in a remote part of the world in the Aegean Sea, and the nearest hospital is about 5 days away, and you get bent? Well, you can have special training and equipment to do something called in-water recompression. And it makes sense. If I get bent and I'm up to surface, put you back in the water. Well, it sounds pretty simple, except that you've got to do it on 100% oxygen at 30 feet. And we risk stratify the divers. If they're really severely injured, you can't put them back in the water. So you have to have an alternative. The alternative can be having what's called a hyperlight, a portable hyperbaric chamber that is collapsible. It's got a Gore-Tex, Nomex material with 2 end caps. It fits in a container and can be opened up on a submarine or an expedition vessel. And you can do a table 6 in one of these chambers. Now, this is 24 inches in diameter, and you are like this for 5 hours. And you're on a ship rocking back and forth, right? So it could be challenging. The only way to get medications is there's a lot. You'd have to put your hand like this and reach for a pill and then take that. And they'd go in with a bottle to urinate and a bottle of water. That's what you would do for your 5 hours on a walking boat. in water recompression, think about. So I'm putting you back in the water, hypothermia, right? I can get worse, right? I can decompensate. I can aspirate. So you need to do this on full face mask, right? So you need special training equipment. And God forbid if I end up having a seizure because of the high concentration of oxygen at 30 feet when the sharks are circling around. I want to just illustrate that as to be a complete discussion. Okay, so what's a diver to do, right? Come to the surface. I recognize you don't look good. I'm going to confront you in a nice way and say, hey, you don't look good. Are you okay? Let me give you some oxygen. Let's get a story. You got to stop that dive. You got to get everyone engaged on the boat, boat captain, calling 911, returning to port. Everyone's got to calm. Don't overexert yourself. Oxygen, first aid, call 911, right? That's just the way it has to go, right? All things stop on the boat operation. You have one thing to deal with, and that injured diver, okay? Again, calling for proper transport would be important depending on where you are. And then hydration. Now, clearly, if you're conscious and alert, maintaining good hydration, oral hydration is fine. If you're sort of in and out of it, you don't want to give the diver anything to drink because if they become unconscious, they could aspirate on that. And then it would be really important to understand the dive profile. So, for example, if I came to the surface and was found unconscious floating on the surface, right? Unresponsive immediately on surfacing, what are we thinking about? AGE, right? Or serious decompression sickness or some other medical issue, right? I ran out of air or whatever point. Okay, but a combination of those things versus an hour later, I'm starting to walk like this on the boat, maybe decompression sickness, right? Versus AGE, but something isn't right, okay? Versus if I'm walking like this and my facial is numb and I was on the boat, but I never went in the water, I'm thinking the guy's having a stroke or maybe hypoglycemia or some other medical issue, right? And then, you know, getting a list of the medications, again, there's HIPAA and all this other stuff, but getting all that information gathered and individually, you should have your own personal list attached with you. So if you are taken to an emergency department, they know exactly what your medical issues are. So I like this slide because it puts together all the many aspects of the 6 kinds of divers with the 6 risks and the 6 aspects of fitness to dive. Each of us are responsible for addressing these components of fitness based on the type of diving we're doing. And it's a daily event. I may be fit to dive yesterday, but today I woke up and I'm depressed, anxious. I haven't slept for 2 days, right? I've lost my job. Is that like the best day to dive? Maybe for some that'd be a perfect day to dive, right? For others, you may want to just hang back, okay? If you do have a medical condition, right, it's important that you address it, right? Discuss that with your physician, come up with a long-term plan. It doesn't mean you're never going to dive again, but what you need to do is meet certain requirements to get you back so you're fit to dive based on the type of diving you're doing, the work of diving, work requirement, and the classification of diving you are. I'm preaching to the choir. Everyone's here to learn, so diver education is important, but we've got to be able to get this to others. And now that you have it on Zoom, hopefully you have access to a lot of people in a lot of different directions, and certainly training, working with your dive shops, training organizations to really enhance your skill and knowledge on a regular basis is really an important part of that knowledge and skill set that are required for all of us as divers. And then I don't care what training organization you go with, you should be current in CPR, AED, first aid, and emergency oxygen usage. This is an old cliche of plan your dive and dive your plan, but it really is a relevant concept in today's diving world. So again, adequate training is really important. CPR, first aid, and oxygen use. So we all need to promote good cardiovascular health. I mentioned diving fatalities, 28% are associated with a cardiac illness, cardiac disease. So that's something we can identify and we can treat and we can minimize that risk. Decreasing depth and time. So yeah, if I'm a warm water diver diving at 20 feet, I'm okay, right? But if I have an unstable cardiac condition, even at 20 feet, that could be a problem, right? I still need to have good buoyancy and training and all those other things, because if I make a rapid ascent, I could end up with a fuel gas embolism. So on a day-to-day basis, what I always do is before I put my fin in the water, I kind of do a checklist. Am I okay? Because if I'm not diving, right? That's simple. Okay, so overall health is important, and then developing confidence in your abilities as a scuba diver. So in that mind, I want to thank you. I really would invite you to, log on to the Apple, Spotify for the Fitness and Diving podcast. We have great speakers. Doug Ebersol is a cardiologist. He's talking about heart fitness and diving. It's probably the most popular of all. The podcast, Fabian Cousteau, we're talking about his upcoming, diving, his previous exposition here when he was on Aquarius Reef Base. Mike Rothschild is in ear, nose, and throat, talking about comedy and key problems. We're talking about pulmonary. I have a pulmonary doctor. And we also have Richie Kohler, who's talking about expedition and aging as you dive into diving. So with that in mind, I want to thank you for your attention, and I'll open up the questions, whether it's here or afar. Thank you.
That was excellent. That was excellent.
Thank you.
You didn't mention PFO.
Right. I did. And
Yeah.
so
And I'm sure you could go on for another hour.
Yeah. Well, actually, instead of doing that, this is what I would like to mention. This is for my friend, Julio Garcia, who's a nurse, hyperbaric nurse in Spring Hill Medical Center, Mobile, Alabama. He treats injured divers in the multi-place chamber. These are the DCI cases for 2022. And I want you to look at the cases that he's getting from Panama City and Pensacola, presenting to his for the first treatment at 23 hours, at 18 hours. Significant delay in getting to his facility. It's more important than PFO. We're not going to belittle that. I just want to show you this, that if you happen to be in the lower Keys and they have a hyperbaric chamber and the doctors are there that day, you're diving down the Keys and you get bent, they take you to the hospital, they throw you in the chamber and everything looks good and hopefully you get in early enough and you do okay, right? But if you're in Panama City or Pensacola, the nearest treating hospital isn't in Florida, it's here. And with delay of going to the emergency department, getting a medical workup, getting transportation, and then making the call and getting staff to come in, they're inordinate of 24 hours in many cases. 24 hours, 11 hours, 17 hours from the time they first get ready to go. Yeah.
Let's not forget pride.
Well, that's a separate issue. I'm not talking about you
I've
delay.
seen it twice.
Yeah, no, I get it. But I'm not saying I'm not going, don't call 911. I'm going to be in my hotel room and then you go. I'm talking about these are people that are in from the time they first go to call 911 to the time they transfer. There's probably delays on top of that. So I think this is an important concept that not every facility, not every location in the United States or the world has access 24/7 to hyperbaric chambers. So wherever you are diving, it would be really important for you to kind of find out where is the nearest treating facility, particularly if you're going to go out to, the Andrea Doria, like where is the nearest chamber if I get bent? Where am I going to go? That kind of thing. But it could also be if you're in the Caribbean or Bonaire or where else, what are the treating facilities? Or Panama City, for example. Now, you asked the question about patent frame in O'Valley, and I don't want to go into detail of that, but for everyone, when we are in utero, we have a connection between the left and right atrium. It's called a frame in O'Valley. And what typically happens is the blood flows in that circulation through that little hole. When we take our first breath after we're born, that little hole fuses or closes. And about a third of the population, that hole never closes. So we're born with a patent frame in O'Valley. Never causing a problem because it's just a small little jet of blood flow. But now that I've got nitrogen bubbles going the circulation, it might end up going to the right heart into my brain, and I could get decompression sickness. Patients who have frequent skin bends can have an associated with a patent frame in O'Valley. Patients who have what it used to be called a non-justified decompression hit, right? Well, you can get decompression at 40 feet and following your dive profile. So, if you're getting sort of unjustified decompression illness, then you may have a patent foramen valley. But many technical divers, right? They're deco divers, right? A deco dive can get bent, right? Is it justified? Well, it's not a recreational dive. So if you have a patent foramen valley and you get decompression sickness, there's a medical treatment for that where you can close the hole. Even by closing the hole, there still can get some leaking through that. There's risk to doing the procedure. Doug Ebersol, the cardiologist, actually has a great discussion. Hey, that's a good lead-in. You can listen to my fitness and podcast on patent foramen valley. He'll give a great discussion by cardiologists.
By Eversole?
Yeah.
Yeah.
Okay.
What I was gonna ask you is if you could maybe show us on that ultrasound video that you had, where that, where the PFO
Sure.
might normally be.
That's a really scary video, considering that those are, if we're everyday divers, that's happening to us and you just don't see it.
Well, I think what's interesting, the research that's done everywhere in the world right now is to look at sort of hardware and software where we can monitor divers continuously while they dive. So we're really good at evaluating a diver before they go in the water and when they come out. But imagine if we could evaluate you continuously while you're diving, measure the amount of bubbles you're producing, put a feedback into your dive computer that will integrate and tell you, you need to come to the surface slower, you need to hold your breath, make a slower ascent, do a deco stop because you're producing so many bubbles. Now, what we don't know is those look like a ton of bubbles, right? They don't have any symptoms. So there's not going to be a correlation between making bubbles, number of bubbles without symptoms, right? If you can say, if you have 20 bubbles and I have back pain, then that's my cutoff, right? But that's like a lot of bubbles, right? So we don't have enough information right now. But again, the goal would be, continuous monitoring and be able to monitor even topside. So if you were able to communicate your heart rate, blood pressure, pulse to your instructor above, right? Running out of problems, air coming out, kind of thing. Yeah, no, one more. There we go. Okay.
I'll take the.
Yeah, thanks. So these two chambers are the atrium. That's the ventricles, and this is the septum. A hole between the right and left atrium would be that foramen ovale that we're born with, we're in utero with. And as we take the first breath, it fuses with a muscular wall.
Well, now how could you tell? That almost looks like there's a hole there.
Well, you can't really tell with this. I mean, this is done in a shack at a dive site, right?
Yeah.
But typically what you would do is you'd actually inject in bubbles. And the other part is that you don't see the bubbles going across the hole,
Mhm.
right? If you had a hole there, you would see the bubbles going from here into there. So that normally when you do a bubble study, you inject air into a patient in the hospital while they're doing the echocardiogram, and you can see the bubbles come in and go right across. So he doesn't have the patent foramen valley because we've done essentially a free
Yeah.
bubble study.
Yeah, that's become a big thing in the commercial diving world because our dives are so well planned and monitored that normally if there is a hit, it's an undeserved hit.
Right, and well,
And many times that diver has a PFO.
right, well, a third of us do.
Yeah.
Right, so the reality is, what would be the utility in doing a echocardiogram bubble study on every diver? A third will have but not a third of us are getting decompression sickness. So if you're gonna say you can no longer be a commercial diver because you have a PFO, but I've never been bent, I don't care, I don't want to take the risk, you're out of a job. That doesn't make a lot of sense, and I know the ADCI is trying to figure all that out, everyone is, right?
I've known about PFO since the late 80s,
Yeah.
early 90s, but it still is not a requirement to get tested.
Oh, here's that picture of the PFO, you can see that.
We have some questions
Yeah.
online.
Okay,
Okay, this one's from Dan Orr. Hi again, Dan. He asks, what is the risk of immersion pulmonary edema in recreational scuba divers?
that I don't know the exact number. So I can't tell you the actual risk. I can tell you that the risk goes up in those who have known heart conditions, a heart disease. So I can't give you a percentage on this, I don't know.
So just in case they can't hear, Julia,
Okay, so
restate the
Dan
question.
Orr, is that correct? Dan Orr asked the question, what is the risk or the incidence of emergent pulmonary edema in recreational scuba divers? And so I don't have the actual number, but I can tell you that those who get emergent pulmonary edema are those who are more likely to have unknown or known heart disease or heart problems.
This one's from Charash. For DCS risk reduction, what are your thoughts on using surface gradient factor to monitor theoretical inert gas living and using it as a guide on how much to extend the safety stop?
So I'm not going to address that question. The question was, what about using repeat that?
Surface gradient factor?
Surface gradient factor. Because I'm not a dive instructor, I'm not going to deal with discussion about surface gradient factors. Okay.
This one's from Jared. Is hyperbaric treatment the definitive treatment for AGE as well as DCI/DCS? How would someone administer treatment in an austere environment?
Right. So I think the answer is that the first treatment is going to be surface oxygen. That if you are in an austere environment, like we talked about, in-water recompression would be an option, but you would have had to prepare for that in advance with training, equipment, which if you haven't done so, you're not likely to have it on hand. Those are typically military or very technical divers, expedition dives that would be doing that. But for the typical recreational dive that we would do, we would not be doing it. If you're in an austere area, the question is, you need to have prepared in advance what could be your option. Going with our hyper light, which is a portable chamber with proper equipped people and trained people, would be important, but it's also very expensive. And to have the equipment training is really a challenge.
Last question is from John. Any effect on diving issues related to prescribed blood thinner use or warfarin?
Yeah, so the answer is that there's a whole discussion on medications and diving. And so what I would suggest is that the medicine itself is not going to preclude you from diving per se. The reason you're taking it is something to consider. If you're taking it because you have had a blood clot, if it's in your lung or leg, right, that has to be evaluated by your oncologist, hematologist, pulmonary vascular team to determine if it's safe to dive based on whether the clot is still there or not. And then separate of the reason you're taking it, let's say for a blood clot and or because of the risk of atrial fibrillation, blood thinners themselves are risky in the sense that if you have any traumatic event while diving, so you hit your head, you fall, and you start bleeding, how will you deal with that? Now, as a commercial diver, if you are on a blood thinner, that would be an absolute ADCI contraindication to diving. As a recreational diver, you would need to seek medical advice and guidance. But I would say that if you dive on a blood thinner and get, let's say, arterial gas embolism and decompression sickness and barrel trauma at 60 feet and come to the surface and you start bleeding in your middle ear on blood thinners, that could be a problem, right? And so the answer would be that each blood thinner is separate and unique. Each individual needs to consult with someone who has knowledge in dive medicine to fully answer that question. So it's not like an absolute you can't dive, but it's something that needs to be evaluated on individual basis. And I know there's questions here. Yeah.
COVID and diving. Even in mild cases, there's some that believe that your full pulmonary function doesn't bounce back, for a few months or a year. So what are your thoughts on that? And how do you think there's any special workup that's needed for somebody that's had COVID before they resume diving?
Yeah, so I think that there are clear guidelines to return to diving after COVID. So you have to establish if there was pulmonary, so lung issues versus cardiac issues versus neurologic issues, right? So on the pure of lung issues, right? If you've had pneumonia where you were hospitalized, put on a ventilator, right? To return to diving under medical supervision, they would typically do specific testing like a CAT scan of the chest to see if there's any anatomic defects. Pulmonary function studies perhaps would also be important. And at that point, they can establish whether you would be able to return to diving. But it's an individual's basis based on the degree. If I had COVID and all I had was, brain fog, right? I may not be able to dive for quite a while, right? My lungs are perfectly fine. I don't need pulmonary testing if I don't have any pulmonary conditions. Yes.
Thank you. Given the fact that I saw one of your tables, as a preventative measure, you were suggesting to use nitrox in these air tables, which to me makes a lot of sense. Now, I'm wondering because the landscape of the divers have changed, actually over my time. I am now no longer 25.
Right.
I'm no longer in the Navy.
She just elbowed you. I'm not sure.
That's right. Yes. So I'm just wondering if there's any research underway to more or less stratify the dive tables for the new demographics. So we've got people diving into their 80s at least at this point because of life change. Well, I haven't hit 80 yet, but 70s. And we have people in their 20s. So I'm wondering if Ann is looking into trying to come up with better estimates because as you said before, no one meets the normal distribution. Therefore, nobody, the dive tables are really not valid for anyone. We should take a minimal amount of care, slack factor.
Right.
So I'm wondering if there's any research.
Well, there is none through Dan that I know of. There might be some worldwide, but I'm not aware of that. I think that for them to redo dive tables based on age and then factor in medical conditions would be really challenging, right? Because, I may be 80 and in better shape than a 20-year-old, right? And perfectly fine to dive, right? I may be 40, obese, shorter breath with type 2 diabetes, right? And probably should not be fit to dive at that moment. So it'll be really challenging to adopt the dive profile. I think it has to be done on an individual basis. And for me to say, go to a physician who knows knowledgeable in dive medicine isn't practical because there aren't a lot of us around. And it's not easy to find someone who can sit down, review your individual profile, life history, and put the best plan in. But we are out there. In the larger, there are 7 or so hyperbaric programs, training facilities where they have fellowships for undersea and hyperbaric medicine. They have dive clinics. So there's one in Louisiana, there's one in Philadelphia, there's one in Syracuse, there's one in San Diego. So there are places around. There are also physicians like me who can see you in the office and sit down and do a consultation and risk stratify you. But it's hard, it's hard pressed to find someone if you happen to live here in town.
Thank you.
Sure. Any other questions?
Yes, this one asks, how many hyperbaric centers are there in the USA?
That I can't, yeah, well, the answer is it's very common, but they're using hyperbaric to treat medical conditions. And those are hospital type programs, but then there are a lot of there are non-hospital hyperbaric programs that are treating things like anti-aging and a variety of conditions. So I don't have a true number. I would say well over 1,000 or more, but that doesn't mean much for us as divers, right? As I said, in Connecticut, there are 32 hospitals, 22 with hyperbarics and none with emergency.
All right, can I ask one more?
So the best way to find a location for a hyperbaric
Well,
for a diver would be
yeah,
through Dan.
through
or
Dan,
through-
right. If you call Diver Alert Network and say, I'm running to the nearest emergency room because I'm bent. And when you get there, if that doctor feels you need recompression, they're going to call them up and they can have a conversation. In addition, if you don't necessarily need to run to the emergency room, but you have a question about your diving medications or diving questions related to your healthcare, you can call Divers Alert Network. Now, what they don't do is the Divers Alert Network is typically not going to say where or all the hyperbaric programs at this moment for this reason, that at 5 minutes from now, that can change. And it's something that is updated in real time, because I may call them from my hospital and say I'm available this week. And then a week later, I'm no longer available because the chamber's down. Divers Alert Network may not have that information. So, it can be challenged. But I think the key is to call Divers Alert Network and get that will be important.
John has another question.
Yeah, what's your opinion and what's the general consensus about diving with a pacemaker?
So the question is, you can dive with a pacemaker, but it's not if you have a pacemaker, but why do you have the pacemaker? If you have it because you've had a rhythm disturbance and that rhythm disturbance is clear, and from a cardiac perspective, you have a normal stress test echocardiogram, you don't have any active heart disease, and the pacemaker has been pressure tested for the depth that you're going to be diving, you could dive. Okay, now defibrillator pacemaker would be an absolute contraindication. The defibrillator pacemaker means that you have the potential for your heart to stop, go into a life-threatening ventricular arrhythmia, and it will defibrillate while you're at depth, and that would be an absolute contraindication.
Do you happen to know personally what the maximum depth rating is on any particular pacemaker?
No, because every company will pressure test the device, and when you have a pacemaker, you call the company and they'll send you a spec sheet that will say this has been pressure tested to 3 atmospheres. If it's been pressure tested to 3 atmospheres, you shouldn't dive. We'll put you in a hyperbaric chamber to anything more than 2.9 atmospheres pressure. But some have been pressure tested to 5 atmospheres. I'm not imagining a lot of people on pacemakers are going to be diving to 5 atmospheres, but that would be my guess.
John volunteering.
Well, thank you all for being here. Thank you all for participating on Zoom. If you have any questions on Zoom, you can put them in the chat. If you're watching it on the History of Diving Museum YouTube channel, we monitor that, so you can put questions in there and we'll get back to you. So thank you very much
Thank you.
for being here today. As a speaker and volunteering your time, we give you a 1-year History of Diving Museum membership, so you can come here 362 days because we're closed 3.
Does it include a room?
It does not include a room, but thank you very much. And
Thank you.
here's a little
Oh, thank you so much.
gift. So, thank you.
So thank you for your attention. I really appreciate the opportunity to be here. Thank you.
All right, and we're gonna say goodbye to YouTube.